Good evening, everybody, and welcome to Beyond Telehealth. And I'm Dr. Lisa Finkelstein. I'm going to be your host tonight, and we have a exciting guest, Kevin Zhou from Harmonize Health. Hi, Kevin.
Hi, Lisa. Great to be on the show.
Thanks for joining. So this is going to be fun. So Kevin and I met a little while ago with a combined endeavor through the hospital. And I thought it would be fascinating to sort of go towards the technology side of things. And so, Kevin, let's introduce yourself and tell us how you got into the field of healthcare outcomes. How did it all start?
Sure. So a bit of background about me. I'm an engineer by training. So I have degrees in biomedical engineering, undergraduate and master's degrees from University of California, Berkeley, and then Duke University, respectively. And I'm very classically trained in just kind of benchtop work, kind of mechanical programming, et cetera, just to make devices and firmware. And so that's the world I come from. And at my previous company, which I spent around 7 years at, we specialize in making high-tech injectable biosensors. So these are sensors,
Injectable.
correct. So they are implanted under the subcutaneous skin layer. And they're able to accurately track analytes such as tissue oxygenation, glucose, lactate, et cetera, or at least far more accurately than that of traditional wearables. And I think the technology itself worked pretty well. So we were able to stream high resolution data from inside the body to a cloud from pretty much anywhere in the world. But as with kind of all invasive technologies, we were really, the burden was on us to really prove, outcomes and convince people that putting things in your body actually did lead to better health, because that's the ultimate key to monetization. And so we ran a lot of clinical trials where we tried to deploy these in hospital systems. And it was a very hard lesson that we learned, which is that it's not really a sensor or a dashboard that drives your outcomes. It's more so this entire connected process. So all the patient logistics, the education, making sure each patient gets kits or sensors that they understand why they're using it, and then the act of then monitoring them and not just collecting sensor data, but collecting data on social determinants, collecting contextual data that can help annotate some of the vital streams you're getting, and then all the downstream clinical flows. So in terms of identifying when patients are actually deteriorating, facilitating timely interventions, and performing proper post-intervention follow-up. All the stuff I just spewed out of my mouth is stuff that's kind of missing, so to speak, from just a traditional sensor and dashboard kind of setup.
Right. So, I mean, I was just reading an article in Outside Magazine with Tim Cook, who was talking about the watch,
Yep.
right? And all the great things that he wants to happen in healthcare and fitness with the watch. And it all sounds really great. It's not implanted in your body, but it does require that everybody has a watch and knows how to engage with it. And then it's the then what. So
Yep.
in this article, it said, okay, great. It tells a patient that they're tachycardic or that they're in AFib. But who cares about that? Is that clinically significant to that patient? And somebody has to determine that, because oftentimes that piece of information is not meaningful, to
Yep.
make a difference in an outcome for a patient.
Yep. I think really having clinical action as a direct result of whatever monitoring you're doing is what drives those outcomes. And to be able to do it, in a cost-effective manner that makes sense at scale, I think that's what will really potentially change, how care delivery can be done.
So then, how did you get into this world of implanting sensors in your own body to creating this company? Because you're a co-founder.
Yeah. So what we often found was whether it was our sensor system or we also looked at some other competing, remote patient monitoring companies, which at the time, was a relatively new field. And what we found the experience of medical providers was that they would purchase a remote patient monitoring vendor, and what happens is they get a large shipment of devices like into their headquarters, and then their staff is then responsible for taking all the sensors out, putting them into kits, figuring out what sensors go to what patients, then enrolling patients, and then educating patients on why they need to be doing this, and then staying on top of patients and making sure they're adherent. And then they are literally hiring fleets of medical assistants to just manually watch dashboards. So screens, just manually watching them. And then taking whatever data that's shown on the screen, then manually injecting it into whatever triage flows that they may have. So they look at the EHR, they look at some of the vitals trends, and then subjectively decide, should we, contact this patient? Should we do something further? And then creating all the clinical flows afterwards. So it's a process that's really costly, so to speak, and it's really hard to scale. And we find that a lot of medical providers, they just don't have the resources to be able to do this in-house without an overall tool that kind of combines everything together and then makes everything much more efficient.
Okay, so I mean, I've talked to a couple of nurses and nurse practitioners that use Medtronics, which was 6 or 7 years ago that they started with this project. I love that company because I implanted devices in patients for their bladders, for for pain, for frequency and urgency. And this company, they get it. But it is all that. I mean, it takes this humongous village to monitor, and this was pulmonary hypertension, CHF, high risk patients, but it works, and the proof is in the pudding. There's less readmission rates. They ultimately save money. So even though you need this village, and that's costly, in the long run, it saves the system money.
Yeah, I think there's a lot of studies that have been done, in terms of whether it's 50 patients at a time, 100 patients, or 200 patients. Sometimes the durations will vary. So you have studies that are 1 month long, 3 months long, whatnot. But it's really, really tough to find an operation that is actually scaled.
Yeah.
So into real practice, simply because oftentimes in these studies, it's a 1-to-1 ratio of staff to patients, or maybe 1-to-2 ratio. It's very, very focused, but it's not really practical when translated into real world practice, if that makes sense.
Yeah, but see, to me, Kevin, honestly, I mean, real world to me is different than your real world. I mean, you're trying to scale and monetize, and we look at a patient, right?
Yep.
And so, for instance, where I live in Wyoming, there's not a lot of people, and so how do you translate what you're talking about, as a company to monetize this as a vision to what the real world is, which is small rural communities that have pretty sick patients?
Yeah, I mean, I think from a personal goal and from Harmonize's perspective, really is to enable medical groups of all sizes to manage that process that I talked about earlier, with whatever existing resources they may have. So let's just say if you're a small hospital with just a small handful of staff available to do this, you can still provide care for the thousands of patients that you may potentially have under your care much more efficiently, so to speak, without having to hire a ton more staff to manually monitor dashboards, to do all the onboarding, and to do all the logistical, operational kind of labor, so to speak, and to make that much more efficient.
And how? Explain that. How?
Yeah. So what our company does is it's kind of like an all-encompassing CRM. So a CRM that kind of manages the entire end-to-end process. And then if your staff are available to manage parts of this, your staff can plug in and do these. If not, we have contract partners that are on standby who can also help with this. So for example, if you don't have enough staff to do first line of clinical triage when monitoring patients, we have platform partners, let's say nurse call centers or whatnot, who can step in on demand and help with some of that load. If you don't have staff on standby to consent patients, for example, and educate them and ship kits direct to their home, give them onboarding calls and troubleshoot them, we have staff on standby who can help with that as well. Just some examples in terms of connecting the process together.
Okay, I have a question. Does it matter if, I'm in Wyoming, but your staff is in California? Is there a licensing problem?
So we have it's geographical, so to speak. So if you're in Wyoming, we would then contract with a local, let's say, nurse call center that's able to provide, clinical
Mhm.
advice within your region, so to speak.
Right. So you'd have to, we don't have that. I'm telling you, we don't have a call center in Wyoming because I have checked into that. I mean, that's one of the things on my wish list for this state is to be able to develop a nurse call center for this type of program.
Mhm.
Um, maybe that's something we could talk about.
Absolutely, yeah.
Yeah. Yeah. Because there's a lot of wonderful nurses that I think would love to do this.
Yeah, no, absolutely. And just to wrap up the question, our platform is really three parts, or covers three segments. So the first is all the patient operations that may be involved with setting up such a program. So as mentioned earlier, you have your, in consenting, you have your enrolling, you have your logistics of shipping kits to patients, making sure they can use it, they understand why they're using it, making sure they're adherent. That's one piece. The second piece is the monitoring part. So in terms of providing devices that are really simple and easy to use, provide a patient interface that is very intuitive, especially for patients who didn't grow up with technology and are a bit older and sicker. And then lastly is help you set up all the clinical flows in a much more efficient manner. So handling, all your layers of clinical triage, and then also funneling interventions directly to providers in an EHR, for example, or whatever care management platforms they may be using. And then also following up with patients after they've been intervened upon to make sure that whatever was done correctly. And if not, you have to make some adjustments and repeat the process. The entire goal is to make sure you arrive at the outcomes in the end.
You missed a very important piece. How do they get paid for this?
Yeah, so most of our customers are within risk-bearing environments. So risk-bearing means they have an enterprise incentive to they receive most of their revenue upfront, for patients, these care providers, and then they're on the hook for managing the cost of these patients. And so their entire system is incentivized to create very efficient practices to reduce their costs. So in terms of, we get paid by our customers who are looking to reduce their overall bottom line costs. And sometimes we'll maybe take a percentage of their cost savings and let's say what's called a risk sharing contract. In some of the cases, it's just a flat, enterprise fee,
Yeah.
on a monthly basis.
But I think, and this is another elephant in the room, our healthcare system is so messed up
Mhm.
that and broken. You're trying to work within this messed up system. Um, in a perfect world, how would you envision a healthcare system working better um, to get to the goals that you want to get to? Like, give me a dream scenario.
Um, so here's the way I see it. So I think in terms of digital health or remote patient monitoring, I think CMS has introduced some incentives over the past few years that are encouraging, providers and encouraging technology companies to come together and introduce remote monitoring and whatnot, primarily in the form of reimbursement codes. The unfortunate part, though, is I think these reimbursement codes, I think the measures that they are measured against really aren't the correct incentives. So, for example, one of the codes that you get, n number of dollars, I think it's like $40 or $60 per patient per month, is if a patient takes 15 or 16 readings in a month. Another one which you get, I think it was $40 a month, or I don't remember the exact amount, is if the patient spends 20 minutes on the phone.
Right.
Um, if you're looking at outcomes, though, just because a patient is taking 16 measurements in a month, and just because they're spending 20 minutes on the phone, doesn't mean they're getting better. It doesn't mean they're improving. I think digital health ought to be held to, um, I think, different measures that have a direct correlation with how a patient's doing in terms of maybe being on the hook for their overall utilization on a month-to-month basis, and that's worth some kind of reimbursement. Utilization being their actual hospitalizations or ER visits, or some other standard that actually is correlated with their actual health improving, as instead of just kind of surface level measures like did you touch a device 16 times, so to speak.
Right, but I mean, you said so we have readmission rates to hospitals, but there's so much more than that. That's what this term social determinants of health that we've all known forever and ever and ever, but now we have this label is these are very intangible things, and that's why the whole healthcare system just needs to be broomed.
Yeah, I think a lot of the healthcare system is on legacy, fee-for-service infrastructure,
Yeah.
whereas everything has a monetary value, attached to it, and so some systems may be incentivized to just kind of rack up the bill as much as possible
Right.
over
We
every
want
test
you.
in the buck. Yep.
Right. We want you to be sick because if you're sick, you're going to come to the hospital. And if you come to the hospital, yeah, it's a messed up backward system. And so your company, I think, and these companies that are moving in the direction of trying to prove better outcomes using technology, we're getting there. It's just, and the pandemic has helped show how you guys can use technology to keep patients home.
Yep. Yep. Even if it's just through educational purposes, I think people have seen a big impact.
Yeah.
Just,
okay, let me just look at some of my questions here. So, what patient population would most benefit from your vision?
so Harmonize specializes in helping high-risk patients. So these are patients who are age 65 and above. Usually, they suffer from multiple comorbidities, and they're chronic repeat utilizers of the medical system. So multiple hospitalizations and ER visits, per year.
Right.
Yep. And I think these patients, if you can actually identify intervention and educational opportunities for them, can really make a difference in terms of managing their health and making sure they don't, unnecessarily go to the hospital or ER when you can intervene earlier on.
Right. The super users, we call them.
Correct.
Okay, what kind of devices do you have for people?
Yeah, so we are technically a device agnostic platform. So we have a patient interface, and that is in the form of a mobile app, and it can be put on either your own smartphone if a patient has a smartphone, or if they don't, we do give them a cellular connected tablet that has everything, has our interface and everything on it ready to go. And what we do is we ship you devices. These may change over time. So, for example, some patients may want pulse oximeters, right? We have weight scales, blood pressure cuffs. There's also passive sensors like wearables, so to speak, and whatnot. We support both types, and the goal then is to basically for the patient interface, the patient never has to have any setup required. So at no point do they ever see a pairing screen or a setup screen. As soon as they get a sensor, it works out of the box, and their account already knows to pair and configure with this sensor. So it's a really seamless experience from the patient side.
And I can attest to that because we've tested it, and it's pretty easy for people who don't know what they're doing. You talked about, I'm going to digress for a second. You talked about these devices that you had implanted subcutaneously. What about the devices that are from Boston Scientific and other companies where they're in the heart and they are, do you interface with them at all?
Not yet, but it's something that we're super interested in.
Yeah.
I think our goal is to be able to help medical services manage this entire process. And
Right.
by process, meaning the entire remote care, kind of spectrum ranging from the logistics, the patient operations, all the way through the clinical flows. And then you can then attach really awesome technologies to that and really amplify the productivity and output, of the system. So there's a lot of synergy there for sure.
Yeah. I mean, when patients are discharged and they have an implantable device and you say to them, we're going to be able to watch you from home because you've got this device inside of you. I think a lot of patients just have no clue. They just don't know how it works. But once they see it work, it's the same thing with the glucometers that, and all the sensors for that. But they're expensive, and not everybody can afford these fancy schmancy things, unfortunately.
Yep. And even if you have basic sensors, so to speak, like a basic fingertip pulse oximeter or a basic weight scale, if it's connected to that process and where patients can efficiently be connected to clinical staff can efficiently triage these patients and then efficiently create interventions without any, data loss or things being lost in translation and being done at scale. Even that can have a big impact.
Well, that's what this nurse practitioner, this cardiac nurse practitioner, she said, and she's a worker bee. This woman is like on fire. And she says, I get an email, and in 3 seconds I answer the email, and there's like no time wasted. We catch these patients when they think that they're doing okay. We get them on camera if we think there's something out of range. They think they're breathing fine, but they're not breathing fine. We adjust their diuretic, and we avoid a catastrophic situation. And literally, it happens in minutes.
Yep. And then ensuring that that process can really be scaled and be done in different environments of different levels of system readiness and staffing readiness.
Be specific. What do you mean by that, Kevin? You speak in funny terms when you say that.
So some hospitals or some systems are very large, right? So they have a lot of infrastructure in place. They have nurses on standby and whatnot to use. They have EHR systems already, and they have providers who are working in the EHR, and they have a set process. So their providers will not log into any other portal, so to speak. They'll only log into the EHR. Their nursing staff is only used to a certain type of software program or whatnot. We're trying to find ways to bring all these layers of staff together and connected, and so that you can have the proper flow of patient information coming into, let's say, an alerts portal where it's triaged by a first line of clinical staff, and then that maybe get filtered down to a second layer of clinical staff, so to speak, where they do further analysis. Then they package these alerts, the ones who are truly requiring clinical intervention, send them off to a physician, and have the physician, who only logs into the EHR, by the way, be able to receive it properly and then make an informed decision within minutes, make an intervention, and also figuring out what intervention the physician did, and having the first line of clinical staff be able to then follow up with the patient later on to make sure that intervention was done correctly, so to speak. There's a lot of integrations involved. There's a lot of information flow involved there, so to speak. That's the problem that Harmonize is trying to solve through our all-encompassing CRM. On the flip side, there's some other systems that are very small, whereas they maybe only have a few pieces of clinical staff available to do anything, so to speak, and enabling them to have a process that may not involve so many layers, so to speak, but it still can accomplish the same goal, and having the system be flexible enough to fit in these different environments. That's basically what I mean in terms of different levels of staffing readiness, different levels of system readiness.
Right. Because right now it involves, phone calls and visits and walking down the hall and,
It's done on Excel. It's done on pen and paper, word of mouth. Yeah.
Right.
I don't know if you've ever played the game Telephone. We have 10 people sitting in a circle, and one person whispers something to the next person's ear.
Whisper down the lane.
Yep. And then by the time it's reached the third or fourth person, the word is completely changed. The meaning is completely changed. That's what's happening right now.
Yes.
And we're not saying that you have to get rid of all these layers, but if you had a CRM that could talk to all the different technology components involved.
What does CRM stand for?
So it's actually stands for Customer Relationship Management. That actually originated from a company called Salesforce. So what Salesforce does, it allows you to create these pipeline operations where you have different components involved of either customer contact or actions that need to be done at different stages, and it helps you manage that entire end-to-end process very easily on one single route. So the term CRM now has been applied to other industries, even though they may have nothing to do with customer relations. but it basically talks about a long, connected process with many components involved, many integrations along that path, and be able to manage all that under one single roof instead of being disjointed. Having 10 people sit in a line, each person managing their own thing, and then just hoping it works.
Right. CRM. Well, yeah, I mean, the whole patient experience is changing because of that mind shift, or that shift in the way we think about things. And I can tell you that physicians don't get it at all.
Mhm.
And one of the things that we talked about. So again, let's go back for a second. You have a degree in biomedical engineering, and you said that it's bench work. It doesn't really correlate to real life, real world things. Same thing with physicians, right? So we learn these things. We learn how to be a good doctor. We learn how to take care of a patient. But what we don't learn is really how to be efficient, and to make the outcomes the best that they can be. We're not taught that. So for us to make this leap using technology with what you're talking about, unless they're starting medical school maybe now, doctors don't understand what you're talking about.
Yeah, and I think we want to be able to accommodate that as well. So if they, like I was saying earlier, if they want to just stick within an EHR that's all they're familiar with, that's okay. Want to make sure they can stay in the environments they're comfortable with, but still manage the overall process, so to speak. And for each kind of component or each staff that's involved in any step in the process, to make sure that they receive specific instructions on here's what to do, here's what you have to do next. You can use whatever tools you want, but from a high level, still manage that process and connect everything together.
Yeah.
So that's kind of our goal.
These are lofty goals, Kevin, and I'm right there with you. I'm right behind you. I think what you're doing is really fantastic. Um, Let me just see. Um, so here's just another specific question. How long does it take to set up an RPM program in an ideal environment?
Yeah. So if you were to kind of set up a traditional RPM program, so that meaning, let's just say we have some CHF patients and we want to monitor their weight, so to speak, and we want a dashboard and we want a basic alert threshold which is every single time they gain, was it 2 pounds between measurement, that triggers some kind of notification or alert.
Yeah.
That's something that can be set up within days. It's very, very easy. It's pretty straightforward.
Okay.
But when you're talking about an encompassing program that involves kind of here's your hospital system, here's the resources you have available, here's how you want all the escalation flows to happen between this first layer of medical assistants who looks at inbound alerts, to this layer of nurses who then processes some of the patients and triages them, to this layer of physicians who makes interventions, then this routing it back to your first line of clinical staff to do follow-ups afterwards, and also handling all the enrolling, consenting, onboarding. That takes longer, so to speak. Also
Yeah.
identifying patient populations and figuring out which ones could best benefit from these programs, and then also figuring out what cadence of patient-reported outcomes you want to track from these patients, what kind of questionnaires you want to push to them, handling all the individual troubleshooting, et cetera. That takes much, much longer. We
And
could definitely, yep, we could
ongoing.
definitely, yeah, exactly. It's ongoing. It's an ongoing process. Yeah. And we could definitely just ship you a carton of weight scales and say, here's a dashboard, here's some accounts, have at it. But that really won't drive any outcomes.
Right. Well, I'm very jealous of Intermountain, and I've worked with them for several years, and I know that you're working with them, and they are an outcomes driven health system, but they also have that sort of dream world situation with the way that they're set up, which is not most health systems. But I certainly think that you guys are going to be a model for the country to look at, and move forward.
We hope so. That's really definitely one of the biggest goals for us.
Yeah. Well, this was, I mean, I learned so much by talking with you and hearing how this all works. Each time I pick up a little more information. Is there anything else you want to add? Anything that you want to leave us with?
Um, I mean, not. I'd say nothing in particular, but really just the message is it's not a sensor or a dashboard that drives outcomes. It's the entire process, and that process can be complicated. And I think the health system as a whole, when we get to the point where we can make that process easier for kind of medical groups or medical providers of all sizes to do efficiently, without having to hire thousands of or fleets of medical assistants when they want to scale this process up. I think that'll be when kind of remote care, healthcare delivery will really change.
And if we can work together, right? We can work with technology, people like you that get technology. We have such a bad taste in our mouth because of the EHRs and how that
Yep.
was just thrown at us in a very disconnected way, sort of how you learn biomedical engineering.
Yep.
That we need to partner together to make this work. I think would be the most beneficial. So I look forward to working with you.
Yeah. No. Likewise. Yep.
Yeah. So, Kevin, hold on one second, but I'm going to end the broadcast, okay?
Sounds good.
All right. Thanks again.